am the coordinator of PPCL, which is the provider-to-provider consultation line. Today, we have Dr. Olivier is presenting on pediatric psychosis and treatment. I want to welcome everybody. We're going to admit folks as they come in. Your attendance is automatically captured through your link, so you don't have to enter your information in the chat, but it'd be great if you wanted to, and that way we know a little bit more about you. But this is our agenda. We're going to follow as close as possible just for time constraints. We're going to do brief introductions of our hub team, and then Dr. Olivier is going to present the didactic, and then Emily Terrell has graciously volunteered to present our case for today. And then that'll lead to clarifying questions with recommendations from participants. And then we'll wrap up and have announcements for the next meeting. So some brief introductions. My name is Jody West. Like I said, I am the coordinator for the ECHO, and I am the program manager for the provider-to-provider consultation line. We provide mental health consultation for providers across the state of Louisiana, focused on mental health concerns for their pediatric or perinatal patients or clients. And pediatric is 0 to 21, and perinatal is during pregnancy and that 1 year postpartum. If you scan this QR code, it brings you to our website and also where you can register for the program. And by registering, should take no more than 3 minutes. It gives us information on how to contact you, and it'll add you to our newsletter list where you can get program updates, other trainings we may offer in the future, upcoming activities that you may benefit from, as well as ways to contact us should you have a question that you want to talk directly to one of our mental health consultants or a psychiatrist. So I'm going to leave this slide up while Dr. Olivier moves forward with introductions of the hub team.
Sure. Hey, everybody. Welcome back. I'm Dr. Olivier. I'm a pediatric psychiatrist here in Lafayette, Louisiana, at my private practice, Bloom Mental Wellness. I'm also the facilitator for these sessions, so I'm the clock manager trying to keep us on time, including my own didactic presentation today. But I'm going to ask the hub team to reintroduce themselves this morning, starting with Ashley Hutchins.
Hi, my name is Ashley Hutchins. I'm a psychiatric nurse practitioner at Bloom Mental Wellness in Lafayette, Louisiana.
Thanks, Ashley. And you might notice we have a switch in pediatricians. We have Dr. Cocky joining us as our hub team expert in pediatrics.
Yeah, I'm a general pediatrician in Broussard, Louisiana, taking the big shoes that Dr. Katie Queen left behind. Just here to help out the hub team as best I can.
We appreciate you. We're excited to have you, Dr. Cocky. Dr. Queen moved on up to the national level with the National ECHO, doing presentations as a childhood obesity expert. We also have, you met Jody, who is our program coordinator and does a lot of the behind the scenes work. And also we have Lena Reggett representing.
Hi, everybody. Oh, sorry. Hey, everybody. Lena Reggett. I'm one of the mental health consultants with PPCL and do a lot of the IT support with the ECHOs.
And that's your hub team. And so for the first part of this session is going to be the didactic for about the next 20 minutes. I'm going to ask you to hold your questions to the end. And then for the second part, we're going to have Emily Terrell presenting a case. And that's our interactive portion where I'm going to ask you to unmute yourselves and loosen up your fingers to ask questions in the chat as things come up. So next slide. Today, I'm going to talk about pediatric psychosis. And I know the opening slide said we'd discuss evaluation and treatment. But today, as I was creating this presentation, time flies by with these. And so I've actually cut the treatment part out. And today, we're just going to focus on more of evaluation and recognition of psychosis versus schizophrenia in the pediatric population. So next slide. You can click till all the graphics come in. Thank you. Sorry, I added in those transitions and they're annoying. So I used to work for LSU Health in New Orleans, and one of my roles there was in the first episode psychosis clinic for Metropolitan Human Services District. This was a specialty clinic for ages 15 to 21, and it was designed for young people who were having their first break of schizophrenia. So this is a topic very dear to my heart and that I do feel like I'm an expert on. But I'll tell you, the topic of psychosis is a difficult one. It's confusing and it's not an easy diagnosis to make, even for someone who's supposed to be an expert in psychosis. But we will talk more about primary care roles in evaluating and screening these patients. Next slide. You can click through a couple times. There you go. So my primary objective is to help primary care participants understand their role in recognizing psychosis. Again, we're going to focus on evaluation and screening. We're not going to focus on treatment in this presentation. I feel like that could be a whole separate presentation, and it may be a whole separate presentation. And we're not going to focus on prevention in this presentation. And so my question to you to start this off is, have you ever been unsure about whether a young person in your practice was psychotic or simply imaginative? Have you ever wondered how to evaluate such a patient, like what laboratory tests you're supposed to get, or are you supposed to refer them for neuropsychological testing? So we're going to address all these things today in this presentation. Next slide. So the next slide, this is an article from 2014 entitled "Which Pathways to Psychiatric Care Led to Earlier Treatment and Shorter Duration of First Episode Psychosis." So you're going to see that acronym FEP, that's First Episode Psychosis. And when you see that, we're talking about schizophrenia. And the take-home point I want from this slide is that primary care physicians were the most common first contacts with first episode psychosis. This was 35% of patients. And the conclusion of this article was that there needs to be better links between primary care and emergency rooms and psychiatric services, which ECHO is actually, and the PPCL call line is actually serving as one of those links. So next slide. Another article I wanted to show you was from 2016, was about increased use in primary care during the 6 years of prodromal schizophrenia. So when you hear the word prodrome, that is a medical term for early signs or symptoms that appear before the full onset of a disease. So what we know about schizophrenia is that there's a prodrome of symptoms that usually can happen for up to 2 years or more before you get the official diagnosis of schizophrenia. And what we know is that young people with psychosis go to their primary care providers about 43% more than controls during the first 6 years before diagnosis, and 132% more during the last 2 months. And so the take-home point of this is that if you have a patient that you're wondering about psychosis and they're coming in to see you with psychiatric concerns, you know, that should raise a red flag to you that maybe we need to have a further evaluation for a psychotic process going on. Next slide. So what is psychosis and how common is it in young people? So when you hear me talk about psychosis, I want you to think of psychosis as symptoms. Psychosis is symptoms. And you can have either delusions, which are false fixed beliefs, or hallucinations, which are false perceptions involving any sensory modality. So you can have auditory hallucinations, you can have visual hallucinations, you can have tactile hallucinations, which are touch hallucinations. You can have gustatory hallucinations, which are hallucinations of taste. And I've actually seen those before, but not in schizophrenia. Next slide. So the pediatric psychosis prevalence, this is an interesting fact that I want you to pay attention to. The prevalence rate in the general population, in the pediatric populations, this is kids and adolescents, is 5 to 8%. This is actually really high compared to the rate of schizophrenia in the general population, which is 1%. So in the pediatric population, there's a 10 times higher rate than the prevalence of a psychotic disorder. So psychosis itself and those symptoms, hallucinations and delusions, are fairly common in the pediatric population. And then you're looking at you take just adolescents into account, the rate's even higher. So in adolescents alone, the rate of psychotic symptoms, psychosis, can be 9 to 14%. And then on self-questionnaires, it's up to 25%. So hallucinations and delusions are pretty common in teens, shockingly common. And they're not always benign. So for a long time, we thought hearing voices with insight is not always benign. Like you can have patients that come in and that talk about hearing voices, but they have insight. They're like, I know this isn't right. I know this isn't normal. Why do we make a big deal out of it now? We know that there's a high rate suicide of adolescents that hear voices. And we'll talk about why that is coming up. So next slide. So why is it important to distinguish psychosis from schizophrenia? Again, psychosis are those symptoms. Schizophrenia is a mental health disorder and a major mental health disorder. So schizophrenia is a chronic psychotic disorder. It's pervasive and it's often devastating. It's associated with severe deficits in cognition, behavior, and social functioning. I think of schizophrenia as a neurocognitive, it's a neurodegenerative disease. And so it's a big deal. It's like giving a young person a diagnosis of dementia at a very early age because it is a neurodegenerative disease. Psychosis in itself is not. The onset of schizophrenia is generally between the ages of 14 to 35 years old, and 50% of cases are diagnosed before age 25. So it's a disease that's onset in the young population. The onset between 13 to 18 years old is referred to it's referred to as early onset schizophrenia. And if it's diagnosed before age 13, it's extremely rare, and it's called very early onset schizophrenia. Next page. 20% of adults who carried the diagnosis of schizophrenia became ill before the age of 18. So 1 in 5 patients that go on to have schizophrenia have symptoms before the age of 18. It's just reiterating the fact that this is a disease of young people. So next slide. I've included a couple of articles in the next couple of slides about another reason why schizophrenia is such a big deal. And these are things that were shocking to me and that I didn't even know as a psychiatrist until I started working with the first episode psychosis population. Schizophrenia, this was a study from 2015 that looked at 1 million individuals diagnosed with schizophrenia in the Medicaid population. And what they found was staggering, and that those with schizophrenia were more than 3.5 times as likely to die in the follow-up period compared with adults in the general population. So my next question for you, if anyone wants to take a stab at it, is how much does schizophrenia shorten an individual's lifespan on average? Does anyone want to take a guess? Someone in the chat said 20 years. It's 35. It's 30 years. 30 years. So again, it's a neurodegenerative disease that can be very devastating. So treatment in recent years has shifted to early intervention, early treatment, and aggressive treatment in the young. Next slide. The other things that make schizophrenia deadly is it's the disease itself. It's a neurodegenerative disease. Psychosis in itself, untreated psychosis that goes on and on and on and on, is neurodegenerative in itself. So you get complications from that. Secondly, we get complications from long-term treatment on antipsychotics. So cardiovascular disease and diabetes, that's another thing that leads to preterm morbidity in these patients. Another big complication, it was this article that I posted up here, is that suicide. The suicide rate in young people with schizophrenia is 30%. In the general population, suicide rate is about 2%. In bipolar patients, the suicide rate is about 10%. And now in patients with schizophrenia, it's 30% suicide rate, 1 in 3, which is so incredibly high. So I just want you to take that home with you when you start seeing young people that are presenting with a possibility of schizophrenia. Next page. So true or false? Most forms of psychosis in children and adolescents are a result of schizophrenia. And this one's false. Yeah, false. If you were paying attention, you know it's false. Schizophrenia is very, very rare, 1% of the general population. So when you have a kid presenting with psychosis and you're thinking psychiatric illness, think of all the other things that it could be before schizophrenia. And that's on the next slide. So this next slide is just a table of psychiatric disorders that can be accompanied by psychosis. OCD, trauma, autism, major depressive disorder, bipolar disorder, any of these can have psychosis as a presenting symptom or as an accompanying symptom. So it's important to distinguish which is which because it's different treatment implications. The treatment of bipolar disorder is different from the treatment of major depressive disorder, and all of these are different from the treatment of schizophrenia. So for children, so it's important to note that pediatric patients with bipolar disorder often experience hallucinations and delusions, but they also have mania or depression going with those. For children with psychological trauma-related hallucinations, these are typically associated with nightmares and trance-like states. Psychotic symptoms quickly abate with therapy and social interventions. And then children with autism spectrum disorders may also have odd beliefs. And so believing that they are able to communicate with inanimate toys. And so children with milder forms of autism may be misdiagnosed with psychosis due to their beliefs and social awkwardness. Next slide. And again, you got to rule out medical causes. So 3% of new onset presentations of psychosis can be attributed to a medical condition. Again, you have a kid coming presenting to your practice, it's most likely a psychiatric disorder that's not schizophrenia. And then it's also, you got to rule out medical causes because there's a 3% chance it could be something. And the medical causes of psychosis are extensive, and we'll go through a little bit of that at the end of the presentation. But next slide. So now I've laid a foundation why it's so important to tease out psychosis versus the first break of schizophrenia. And so what are the presenting characteristics of psychosis in children and adolescents? Most common manifestations are hallucinations. These are typically auditory hallucinations. If they're having visual hallucinations, that's actually more rare. And if they're having tactile or gustatory or olfactory, which is a smell hallucination, that's extremely rare for psychosis, actually. We're starting to think more of delirium or like a seizure disorder or something else. They have to have impaired functioning. So when we talk about what is the function of a kid or what is the function of a teen, we're thinking school, friendships, and family. I don't even include hygiene in that one because poor hygiene in a teen it's hit or miss. It's like some teens just don't care. Some teens just don't care about their hygiene and they're not psychotic. So you're looking for impaired functioning, some impairment in school, a decline in school performance. You're looking for a decline in their friendships and their ability to socialize. And you're looking at a decline in family relationships too. So teens with schizophrenia tend to isolate and withdraw from their families and withdraw from their friends. You're looking for a flattened affect. And you're also looking, especially for social withdrawal, and we'll talk about that a little bit more. Caregivers are more likely than their child to report these problems to the clinician. So if the caregiver is reporting these problems, it raises a red flag because a lot of kids and teens will come in willing to talk about depression. But when they're psychotic, they don't see it. They don't have the insight into it. And so they're not going to talk about it. It's going to come more from the caregiver. And then you have to pay attention to developmental delays. So if there's an intellectual disability or autism, you got to rule that out because the kids with those disorders often talk about hallucinations and have weird and odd beliefs too. You have to look for family psychiatric history and any history of abuse or trauma. And then you have to pay attention to your own mental status exam. Next slide. So again, a prodrome is the period that's before the onset of the disease. So it's a period linking pre-morbid functioning to full psychosis. So it's that period before the official diagnosis of a psychotic disorder. A prodrome can last for years. So there might be subtle signs and symptoms for years before a diagnosis is made. So how do you decide, is this psychosis from major depression versus a prodrome of schizophrenia? And number one, if there's a family history of schizophrenia and a first-degree relative, that's a very, very high red flag because schizophrenia is a very heritable disease. Secondly, you're looking for decreased performance at school or work, especially social isolation. So the statistic on social isolation, 70 to 75% of patients with schizophrenia reported a decline in school function and social withdrawal. So if I have a patient coming in, and a teen girl, let's say, and she's reporting hallucinations, one of my first questions is going to be, how's school going? Well, I have my straight A's. You don't have schizophrenia. I can rule out schizophrenia right there because psychosis, like a mental illness like schizophrenia or bipolar disorder, it doesn't discriminate settings. So you can't be psychotic at home and not psychotic at school. You have to, there's going to be a decline and oftentimes kids with psychosis are the ones that are quiet in the back of the classroom. They're not causing a ruckus up front. 15 to 20% of teens with psychosis report self-harm. That doesn't really help with your diagnostic interview though. You're also looking for odd behaviors or beliefs that the patient is not able to explain adequately. So you got to get these kids talking to be able to tease out thought process. The other way too is to get them writing. So if you're not sure, oftentimes I'll have teens with depression that'll come in and they don't want to talk. So if I'm trying to rule out psychosis and they won't talk to me, I start asking for writing samples. Like, do you keep a journal? And I encourage them to keep a journal too, because you can see thought process disorganization in writing too. And oftentimes you can see mania in writing too. Like a manic patient will have writing all over the page and big and small, and it's, erratic. And someone who's psychotic will write psychotic too. Their thought process will be jumbled and it won't make any sense. So that's just a tip. If you can't get a kid talking, you can look at their writing and kind of see and look if it's logical and makes sense. Hostility or suspiciousness that seems to be out of proportion, odd speech, or a depressed or anxious mood that does not fit usual patterns. Next slide. There are some screening tools, but the screening tools are so extensive that they're very complex. And so they don't have any usefulness in a primary care clinical setting. So I'm not going to give you any screening tools from this, because there's some that I use there's one, I forget what the name of it, but it's prodromal schizophrenia assessment, and it's long and it takes hours to do. So it's not practical for primary care use. But these are some things to look for on your interview to rule out a prodrome of schizophrenia. If they're incoherent, if they have thought blocking, so you ask them a question, there's this like delayed response, like they're thinking and thinking and thinking, and then they give you a response, or they just look at you like they're thinking and thinking, and then they never respond. That's called thought blocking. Echolalia is when they repeat themselves, or they repeat words or phrases over and over again. Neologisms, that's when they create a new word that means something to them, but it's not a real word. You can look for the extremes of affect, because I know we're taught to look for flat or blunted affect, but they can be disinhibited by their psychosis too. So you can see silly, goofy, or labile affect as well. And here's a little tip I put in the middle and I bolded it. Orientation and memory are usually intact. If orientation and memory are not intact, you're going to start thinking delirium or some medical cause of psychosis. Prominent difficulties in abstraction. That's a big one. So abstract thought is pretty easy to assess if you can get the kid talking. And so you can look for similarities, like such as in what way are an apple and banana alike? You can look for analogies, like if a tree is to a leaf, what is a flower to? Hypothetical scenarios, if you found a wallet on the ground, what would you do with it? The proverbs that we were taught, don't count your chickens before they hatch. What does that mean? And so in psychosis, you lose abstract thought. So by testing for these abstract thought, you can get a really good picture of their thought process. Next slide. We are running a little bit out of time, but just real quick, the DSM-5 requires 2 of the following: delusions, hallucinations, but they have to be present with disorganized speech or disorganized behavior to make that diagnosis of schizophrenia. So you can't just have delusions alone, and you can't just have hallucinations alone. You have to have those with disorganized speech or behavior. The symptoms must be present for 6 months, and there has to be a deterioration in functioning. Next slide. And true or false, personality test or a projective test increase the diagnostic accuracy in early onset schizophrenia. This is false. They do not increase the accuracy. So I used to send kids with psychosis for projective testing, but what they found is they're diagnostically inaccurate, so they don't help. So psychological testing doesn't always help to tease out psychosis. Next slide. This slide is just showing you all the different medical causes that can have psychosis associated with them. There's a bunch, there's a lot. But the good news is most of these can be ruled out with simple lab testing. Next slide. So the key test, urine drug screen, lab studies, which I've included on the next slide, a list of the most common lab studies that can rule out just about any of those that were on the previous slide. And EEG, so almost 50% of new onset psychosis patients have abnormalities in their EEG. So it's actually kind of high yield, but it's non-specific findings. And there's MRIs are controversial because they're actually low yield, but the peace of mind that you can give to the parents and the patients is high yield. I know if it was me and it was my kid and we were trying to rule out if this is schizophrenia, because I know schizophrenia is such a deadly disease, I would want an MRI just to rule out a brain tumor or anything. Next slide. Like I said, these are the lab tests that you can order, and you'll get a copy of this PowerPoint at the end. And that is it. I will save, I'll put just this slide is on the end because just to reiterate that the National Institute of Mental Health has in recent years, there's been a big push to focus on early onset schizophrenia and treating it because it's such a deadly disease. But all right, that's it for this presentation, and we're gonna go right.
Okay, well, we appreciate Dr. Olivier's presentation as well as Emily's presentation. We are always looking for additional case presenters. So if you have a case that's similar, or Emily wants to bring another case back, you know, we are always every session, and it does not, as you saw today, it does not have to match the topic of the didactic, and it could still be a rich discussion. Because it could be something similar to what you may be experiencing with your clients, or help another participant out. So we really encourage folks to take advantage of the opportunity to talk about your cases, and we're here to help guide you through it and hopefully help your blood pressure not rise. This is a supportive environment of other professionals that hopefully can offer some assistance. So just some wrap up and announcements. You don't have to enter your information for CEUs for attendance because it's done automatically through iEcho now. I will be sending out an email that has the link for a survey. If you are interested or need CEUs for the session, you have to do the survey. Attendance alone does not get provide CEUs for you. So we provide certificates for nursing, physicians, and nurses, social workers. The LPC board does accept it. You'll just have to include the agenda, and the agenda is in iEcho for this session. Our next session is going to be Tuesday, April 8th. And the next presenter, the next session is about disordered eating, where Dr. Andrea is going to present. So we will be posting the didactic portion of this presentation, of this echo session, on our website. We removed the case presentation just in case there's any identifying information, or if someone recognizes information, we want to protect the patients or the clients. So we do take out the case of the recording before we post it. So that'll be all for today. Thank y'all so much. An email will be going out today or tomorrow with the survey link as well as the recommendations for the case. So we hope everyone has a good afternoon. We'll stay on for a few moments if anybody has any additional questions. But thanks again to Dr. Olivier and to Emily for participating today. And have a good afternoon.
Thanks, guys. Appreciate that.